Greetings to you all. My name is Dr. Edward Ngwenya, and I'm a plastic and reconstructive surgeon. In this brief, what I've been requested to do is discuss the acute management of burns. Now, we've only got 5 to 10 minutes, so we will rush speedily along and just be high level in our approach and succinctly define or rather explain what one would do when confronted with a patient who has sustained burn injuries. Now, let's perhaps start off with a scenario. Here's a patient who was perhaps asleep at home. The house caught fire and it was trapped in that house and eventually after some time rescued by the paramedics. And then this patient is now brought to you in the emergency department, and this is where we will then take our management from. So as you receive this patient, remember the principles of medicine is that we first seek to preserve life, then function, and lastly form. Therefore, when a patient presents with burn injuries, we don't immediately jump and treat burn wounds. However, we treat a patient, a human being in their totality, who presents with burn injuries. Therefore, we will then manage the patient holistically. And so in so doing, we then employ the principles known as the ATLS principles, acute trauma life support, which use a simple mnemonic, the A, B, C, D, E, and F. Now, let's succinctly go over that. The patient then comes in. The first thing that we look at as per those principles is A, which stands for the airway. We like to add C, spine control here in. But let's focus on the airway. Now remember, when we speak about the airway, we speak about the upper airway. We speak about the conduit, the pipe, simplistically put, that brings the oxygen from the external environment through the mouth or nasal, auricular, pharyngeal region, and brings it down the trachea, the larynx, the trachea, taking it down to the lungs. Now, we want to make sure that pipe is opened, and it can be compromised externally. One, if a patient comes in and you look at them and you see their neck is swollen, their face is swollen, they are edematous, therefore they may constrict the airway. The patient may have soot in the nasal region when you look, or soot in the mouth, and they may seem quite edematous. And if so, if you suspect airway injury, you hear stridor, you secure a definitive airway, which is putting in an endotracheal tube. Don't play with these patients. Don't wait for later. You suspect it, rather put in a tube. You can always remove one than waiting. You may struggle to put in a tube. Surgical airway stands as an option, but don't take it lightly. Not an easy thing to do in a patient with severe edema, erythema, swollen, burnt on the neck region. You may lose that patient, so first secure a definitive airway. Therefore, we have now secured an airway for this patient to present to us. B, we then look at breathing and ventilation. Now, what do we speak about or refer to rather when we speak about breathing? We're looking at the oxygenation, the ventilation of the patient. Therefore, we're talking about the lungs and what's happening, below our vocal cords. And so what may compromise this? This is when we are looking at, is the patient saturating well? Is the patient dyspneic? We mentioned that the patient was trapped, and thus the patient may have carbon monoxide poisoning. The sets may be deceiving and show that the patient is saturating well. However, with carbon monoxide poisoning, they may be compromised. And they may also have other things because there are materials in the house. Perhaps there might be cyanide poisoning. So in that patient, we want to make sure that they ventilate well. And so we'll be looking at that. And if we are not sure that they are able to maintain their own breathing, we connect them immediately to a ventilator and adequately ventilate that patient. We've cleared B. Now we look at C, which is circulation with hemorrhage control. So when we look at circulation, we're looking at the volume. So we want to know how much fluid did the patient lose. And to do that, we use a simple formula. Many formulas exist, but we would like to stick here, and I would advocate for a Parkland formula. And the Parkland formula, which now we have modified by looking at the constant value. We used to use a value of 4. Now we use 2. We look at 3 factors. We've mentioned the constant. And so we then look at the total body surface area of the patient. And so when we look at the total body surface area of the burns, we are then going to determine this. And how are we going to determine the total body surface area? We are going to look at the simple rule of 9s. And I would thus advocate that you go and look at the rule of 9s. And the rule of 9s will then tell you which areas are burnt when you look at the chart. And in then looking at that, it will then also then give you a percentage of that region. And that is the Parkland formula. We will then also look at the weight of the patient in kilograms, and then take that and reach a quantity of fluids that we are going to then give to the patient. So the formula is thus 4, that's the Parkland formula, 4 times the percentage of total body surface area that has been burnt times the weight in kilograms. And then we receive the total amount of fluid, which we'll divide into 2. We'll divide in half. We will give the first half of the fluid on the first 8 hours of the burns. And then the next 16 hours, we then give the remainder of the fluid. And that is our Parkland formula. Now we've managed C. Which fluid do we use? Ringer's lactate. That's the fluid that we're going to be using. So we give the patient Ringer's lactate, but we are not treating formulas and numbers. We look at the endpoints of resuscitation. We look at our heart rate. We can look at our blood gas. We look at our urine output. And we look at our BPs and all those endpoints of resuscitation and vitals that we have. And so we will then cater this based on the patient that we have in front of us. So everything will be modified therein. Then we move from A, B, C, and we go to D. Now we can look at our disability, or we can then, quantify our burns. And how do we quantify? We're looking at the depth of our burns. Now, remember, burns can be divided into 3 or 4, depending on the classification that you use. The old classification was 1st-degree burns, 2nd-degree burns, and 3rd-degree burns. And that looked at the 3 layers of the skin. Of course, we know we've got the epidermis, looking at the 5 layers or the 4 layers, depending on the thin or thick skin, the type of skin that you have. The strata, corneum, lucidum, granulosum, spinosum, basale. That's the epithelium. Then we go into the dermis, and we've got the dermis divided into 2, the papillary dermis and the reticular dermis. And then we've got the hypodermis or subcutaneous fat. So the burns would then be divided looking anatomically at the structure. We prefer to use superficial burns the word superficial, limiting it there to epithelium, things like sunburn. Then you can have partial thickness burns involving that dermis region. You can have higher up burns, parts of the dermis, which we call superficial partial thickness. Or it can be deeper into the reticular derm, where we call it deep partial thickness burns. And then we can have, of course, deep burns or the old third degree burns, where now we've removed most of the skin and we no longer have skin. And fourth degree burns some use, where it would then relate to, deeper structures, there's exposed bones, organs, etc. Now that we've classified our burns, we are able to treat the burns appropriately. And how do we treat them? Acute management of burns, you will want to put a layer of or a dressing over those burns. And what dressings can you put? There are certain products available. I don't want to name them specifically by the product selling, but there would be a rather early wound management dressings that would put over the burns. Now, shall we put the patient on antibiotics? No. The patient does not have an infection. They've got inflammation. So CRP may be raised, but it doesn't mean the patient has an infection, but rather has inflammation. And so in the early phase of burns, that's not what we're going to manage. And once a patient is stable enough for burns and we can then clean them, we can then take a patient to theater, debride, rather, for lack of a better word, clean the patient in theater, scrape down and remove those burns. Should you keep the blisters? Should you remove the blisters? We know we can remove those blisters, scrape down that skin, and then apply our dressings therein. If it needs skin graft, we've now seen early skin graft management is better to do, but in the early phases, at your level, not being surgeons, you want to just put a dressing and cover the burns and keep the patient alive. And those are succinctly the acute management of burns. We will revise. We look at our acute trauma life support principles, which are A, B, C, D. What are we doing? Securing airway. B, making sure the breathing is intact. C, the circulation using our Parkland formula, adapting the rules of nines. 4, we then look at the degree of burns that we have. We classify it anatomically: superficial, partial thickness, deep partial thickness, or deep burns, and then we manage the patient according to that. And that, ladies and gentlemen, succinctly in 10 minutes is the acute management of burns. I thank you for your attention. Again, my name is Dr. Edward Ngwenya, and if you have any questions, you can simply go down and check more presentations on our YouTube channel, Dr. Edward Ngwenya, where you will get more information regarding the management of burn injuries. Thank you very much.